Cancer, once a taboo topic, has transformed into a condition that can be effectively managed and even cured, particularly when detected early. The approach to cancer treatment has shifted towards preserving organs and enhancing the quality of life. Recent breakthroughs in cancer care have resulted in the possibility of living a longer, higher quality life for many individuals. Through the integration of cutting-edge technologies within the realm of precision medicine, such as targeted therapy, immunotherapy, minimally invasive surgeries and robotics, not only are more personalized and efficient cancer treatments attainable, but patients also experience faster recovery times and prolonged survival rates with improved overall well-being. The primary goal of oncology now revolves around treating challenging cancers as chronic conditions, with a key emphasis on minimizing disruptions to patients' quality of life and daily routines. Today, let's explore the remarkable advancements in cancer care in India and gain insight into the diverse treatment options available to patients. We have with us two prominent oncologists who are at the forefront of change in cancer care, Dr. Haribhakti and Dr. T. Raja. Welcome to the show. Well, Dr. Haribhakti, let me start with you. You know, the cornerstone of cancer treatment is preventive therapy, early detection. What does one mean by early screening and how important is it?
So I want to make a quick distinction between screening and prevention. Screening is what you do to a patient who has no apparent disease, no complaints. So literally any member of the population is screened. And if you detect something, that is known as a screen-detected cancer. Whereas early diagnosis is different in that you actually seek out a cancer and you are able to diagnose it. Now, prevention is something quite apart, because in prevention, you know the risk factors and you try to modify risk factors in a patient so as to minimize the possibility of the cancer ever developing. To give you a very quick example, because this is known to everybody in the world, Angelina Jolie was tested with the BRCA1 and 2 gene tests, and she was found to have a lifetime risk of more than 80%. And therefore, she went ahead and had a double mastectomy with a reconstruction. So this is prevention, where there is no evidence of disease, there are risk factors, and you modify them to prevent the disease. Now, in our country, the practical aspect of prevention can be in the form of tobacco control. I mean, that's the one major cause of cancer in our country. The commonest cancer in males is mouth cancer, throat cancer, lung cancer. All of them are tobacco related. So that is the one intervention that can take away 50% of all our cancers.
Okay, well, point well said. You've recently written a book, with regards to breast cancer as well, and there you've spoken about early screening, prevention when it comes to breast cancer. Tell us more about it.
Yeah, so let me show you. This is actually the book, and we called it Being Breast Aware, What Every Woman Must Know. All ladies need to understand whether they have any modifiable risk factors. There are two types of risk factors, modifiable and non-modifiable. So the modifiable risk factors are known, and they include things like late marriage, late children, late lactation or no lactation, and the non-modifiable factors are genetic factors, like I just told you, the BRCA1 and 2 antigens. So ladies should know about this, and they should also know that screening is possible, very much possible in breast cancer, and the commonest method for screening is by doing a screening mammography. Mammography is an X-ray of the breast. And what mammography achieves very often is to pick up a cancer before it is at all clinically apparent. So before the woman can feel it, sense it, before any doctor examining can feel it or sense it, it gets detected on a mammogram.
Dr. Raja, I want to come to you with regards to the next question. The key question about early screening is that there are only few tests for men and women. For example, for men, it's the PSA, it's mammograms when it comes to women, and pap smears, and maybe the CA-125 and sonographies, and maybe colonoscopies for both. So in that case, how do you cover other organs of the body which don't come under these tests?
See, what we need to understand is that in India, um, more than 1.5 million newly diagnosed cancer is detected every year. That's called as the incidence. Out of that, 80% of them unfortunately present at a stage where they are called as advanced stage and they are incurable. But if it is also known, data wise, that if we are able to detect these cancers at an early stage, then again 70 to 80% of them are curable. So you can completely reverse the situation and the outcome in these patients. But then comes the concept of what we call common cancers and screenable cancers. The common cancers are the breast cancer and cervix cancer in women, and prostate cancer in men. And then we have the lung cancer and the oral and head and neck cancer in both the sexes, lung cancer in both the sexes, colon cancers. These common cancers really constitute the bulk of the disease numerically. And if you look at what is screenable cancers, the top 5 to 6 common cancers are known as screenable cancers. For example, these are either surface malignancies or can be detected by a simple test. Breast cancer can be detected by a mammogram, cervix cancer by an examination and pap smear. Similarly, prostate cancer can be detected by a simple digital examination, colon cancer by a colonoscopy, oral and head and neck cancers by a simple examination, and low dose CT for lung cancer. So that's why the common cancer and the big bulk cancer are all screened by these commonly available, well tested methodologies. All
Sure.
other cancers are then decided based on symptomatology. That's how you really rationalize the screening opportunities.
Dr. Haribhakti, you mentioned BRCA 1 and 2. If in case somebody does test positive for it, what is the general advice? Or is it case by case?
No, I think case by case is correct. And I would go further and say that any advice is completely vetted with, with the patient's immediate family, a genetic counselor, and the doctor. I think everybody should be involved. For example, if a woman expresses both BRCA 1 and 2, then the ideal preventive advice would involve not only removal of both the breasts, but also removal of both the ovaries. So this is a very big decision, and I think we cannot. What I'm trying to say is you cannot treat this as, okay, you've got this, so now you need to do this. It doesn't work like that. There are many sensibilities involved, and I think the implications are huge, as you would imagine. So it's very important that everybody should be on board: a genetic counselor, the clinician, the patient, the family.
Okay. All right. Well, now let's start with, let's discuss the advancements in the treatment of cancer. Dr. Raja, let me start with the diagnosis part of it. How accurate are liquid biopsies for hard to reach tumors?
Oh, they are increasingly becoming popular, and they are becoming increasingly efficient, I would say. We are using it in two settings. One is in the primary diagnosis setting where there is a newly diagnosed patient or where there is a strong suspicion of patient wherein a tissue pathology is not yet established in a difficult to reach site, and that's a very challenging subset of patients, but those patients are now are also there, and wherein I would say that 70 to 80% chance that you will be able to demonstrate the possibility of a malignancy in them. But liquid biopsies are being increasingly used in the secondary diagnosis setting where there is already a diagnosis of cancer, and then you want to longitudinally monitor them for the changes
Yeah.
in the DNA profile, or for the follow-up, or for early detection of the recurrence, or in response assessment. In both the contexts, liquid biopsies are becoming more and more useful, and they are becoming as good as what we call as solid biopsies. Sometimes they are more versatile and more useful than solid biopsies.
Okay. All right. And what about traditional therapies such as chemotherapy, radiation? Have all of these advanced? Have side effects reduced, Dr. Raja? Is it less invasive? And is it applicable to all cancers as well?
Absolutely. Over the past 2 decades, apart from the various improvements that we saw in the cancer care, the best thing that has happened is to improve the quality of life. As regards to chemotherapy, now the drugs have become more and more sophisticated, and we increasingly use what we call as antibodies and conjugated drugs and so on and so forth. And we now have targeted drugs which specifically act on the cancers. And the side effect mitigation, supportive care drugs have improved tremendously. Now we have good drugs to mitigate vomiting and mucositis, diarrhea management, and the neutropenia management have all improved tremendously. With regard to radiation, now the technology has improved to be more and more precise. From the days of cobalt and 3D, 3 dimensional radiation techniques, now it has advanced to what we call intensity modulated radiation, image guided radiotherapy techniques, cyberknife tools, and we now have the most advanced proton therapy. The concept is that the radiation is becoming more and more precise, exactly contouring the tumor so that you can avoid the normal tissue and thereby improve the efficacy, dose delivery, and reduce the side effects. Similarly, with regard to surgery also, the minimal access surgeries have become more and more available across the country. The experience and the prolific use has increased tremendously in all centers, including laparoscopics and robotic surgeries have made it possible to operate even in vulnerable individuals, elderly individuals. So these are all
Sure.
tremendous changes that have happened over the past couple of decades.
Okay. Dr. Haribhakti, when it comes to surgical advances in cancer, I want to talk specifically about breast cancer with you. And what are the advancements there? For example, if in case somebody is diagnosed with an invasive cancer, is there any chance of saving the breast in terms of surgery? And what are the advances when it also comes to, say, reconstructive surgery?
Sure. So let me start by telling you that a diagnosis of cancer of the breast, almost more than 80 to 85% of the time does not mean removal of the breast. Today, and this has been established for the last 30 years all over the world. In fact, a prospective trial from Italy clearly established the safety of breast conservation surgery. So today, a very large proportion of the work we do is breast conservation. Now, in breast conservation also, there is a further refinement over the last 10 years or more called oncoplastic surgery, in which the incisions and the approach is planned in such a way that the breast is practically restored to a normal looking breast. Today, in our follow-ups, very often students find it difficult to tell which is the treated side because the results are so perfect. So I wanted to start with that. Okay? Mastectomy, which is removal of the breast, is required in a minority of patients. Furthermore, if mastectomy is necessary, and there are clear-cut criteria for those who need mastectomy, there is very much possibility of reconstruction, and reconstruction broadly is either implant-based or patient's own tissue-based. It's called autologous tissue-based. So both are very reliable, extremely good with very good outcomes. So today, if you ask me, in practice, for a young individual, and I say young, I mean up to the age of even 50 and 60. And the oldest lady on whom I did a reconstruction was 75. She wanted her form to be preserved. We are able to offer immediate reconstruction.
What about robotic surgeries? Which cancers are they used for? How beneficial is it for patients when it comes to, say, reduced blood loss as well as recovery when it comes to robotics?
Yeah.
And how often is it used in India considering how expensive it is?
Well, firstly, let me take the last point first. It is expensive, but not prohibitively expensive. And I think for those cases where it is indicated, it is very well worth it, because for the patient, it means, like you pointed out, very quick recovery, very good dissection, very safe, and very quick return to normal, so return to productivity. Now, for instance, the entire field of urologic oncology, whether it is for kidney, whether it is for prostate, also to an extent for urinary bladder, robotics has taken over in a big way. Yes, there are those patients, the advanced cases, who will need open surgery, but robotics has taken over in a big way. Another area, robotics really works very well when you're working in a cavity. So whether it is the abdominal cavity, the pelvic cavity, or the thorax. For example, I just said prostate. Prostate is a pelvic organ, and the open prostate surgery used to be one of the worst and most morbid surgeries in the past. And today those patients go home in 48 hours. So it's a huge advance. And I think there's no question about it. It is there to stay.
Okay.
Yeah.
All right. Dr. Raja, coming to you now, what is precision medicine or targeted therapy in terms of cancer? Is it for all stages of cancer, and is it for all cancers?
Yeah, absolutely. So precision oncology is probably the best thing that has happened over the past decade, in which we understand that each patient with their tumor is unique in their own sense, and each one of them have to be treated according to their tumor and tumor DNA profile and so on and so forth. No two individuals, even with the same diagnosis, are same. That's what we understand by precision oncology. We tailor the treatment to the individual, to the tumor. That's known as precision oncology. It is when it was first brought into in the year 2000, liquid malignancies like chronic myeloid leukemias, and later on by 2010, lung cancers became an important example for how precision medicine can be applied in solid tumors. At that time, it was usually applied for advanced malignancies, stage 4 malignancies. But the best thing is that now it is being increasingly used for even for early stage diseases, even for post-operative situations, or even in pre-operative situations. Now we use these kind of approaches, and the outcomes and the long-term survival has tremendously improved. So precision oncology is applied across all stages in across many malignancies currently.
Okay. Dr. Raja, what about CAR T therapy? There is one particular CAR T therapy which has been introduced recently in India, which is by ImmunoAct. It's indigenously made. How much is it used, and what is the price difference as well?
A very important advancement in our country, because this is developed by our own in our own country by one of the biotechnology company, and this has suddenly made the this particular treatment option available to our population. uh, just before 2 years, all of our patients have to travel to other countries, including United States, or to eastern, some of the Eastern developed countries to get access to this particular treatment. But fortunately, over the past 2 years, in our center and many other centers, we started doing clinical trials on with CAR T cells in particularly in lymphomas and leukemias, and the treatment started to become available. Now
Okay.
we have this, NextCar 19, which is an approved option available, developed in our own country. Currently, it's approved for lymphomas, B cell lymphomas, but I think it is also being increasingly researched in leukemias, acute lymphoblastic leukemias, and in multiple myelomas. Very soon, all these diseases will come under the purview of CAR T cell therapy. It's a very important development because it's now an important option for patients who have already become refractory or relapsed to the previously existing therapies, wherein previously there were no options, and this has suddenly become a curative option in those settings. Cost is a
Okay.
very important issue, but what has happened with the development of technology in India is that the cost has tremendously come down.
Sure.
The cost that was 3 crore to 4 crore in the other countries has now come to 40 lakhs, 50 lakhs, by the availability of this particular option in our country.
Okay. Dr. Haribhakti, what about the efficacy of the MR LINAC, proton therapy, gamma knife, cyber knife? How often are these kind of therapies or advancements used now, or is it still used selectively?
So I'll tell you. I mean, it's in continuance with what I think Dr. Raja said some time back, that today we are more customizing treatment. So even where radiotherapy is concerned, it's not as if every patient merits or needs the same type of radiation. For example, to give you a very clear example, if there's a patient with a very tiny tumor inside the brain, deep inside the brain, where you don't want surrounding tissue to be involved, then of course you need a highly focused radiation, and that is where you use the cyber knives and those kind of energies. But what I would like to say as a broad statement is, we are becoming more and more precise in the way we are delivering treatment. So what that means is better treatment outcomes and lesser side effects. And today, at least in a hospital like ours, we offer a rehab package along with radiotherapy, so that the side effects to the patient are mitigated substantially, and we are able to take them through treatments quite well. Otherwise, radiotherapy to the mouth is very, very troublesome. Okay. So yes, we do have the ethos, which is a very it's at our hospital, which is a very advanced type of linear accelerator, and it's called adaptive treatment. It's called adaptive radiotherapy. So since you mentioned others, I'll quickly touch upon them. Proton therapy, available until now only in Chennai, now also in Mumbai. And proton therapy is a particle therapy, which again has great value for certain types of cancers, but is increasing in its utility in other cancers as well. And CyberKnife, which you asked specifically, that was mainly discovered for brain tumors, and it was actually discovered by a neurosurgeon. It was a neurosurgeon who did the research to develop the CyberKnife. So it was developed for treating neurologic cancers, but now it is used even for very precise targeting of other tumors that are treatable.
Okay, all right, Dr. Raja as well as Dr. Haribhakti, it's been a pleasure. Thank you very much for joining in and giving us answers to very crucial questions when it comes to cancer, and especially talking about important topics such as early screening and preventive screening in cancer care as well. Thank you very much for joining.